enlargement may result in a set of symptoms which is usually referred to as lower urinary tract symptoms. These lower urinary tract symptoms can be broadly classified into either irritative symptoms or the storage symptoms, or voiding symptoms or emptying symptoms, or what is called as obstructive symptoms. So one important thing to remember in these patients with lower tract symptoms is there are two types of broad classification of this lower tract symptoms. One is storage symptoms or irritative symptoms. The storage or irritative symptoms usually include symptoms like frequency, urgency, and nocturia. The other set of symptoms is what is called as emptying symptoms or voiding symptoms or obstructive symptoms, where you have got poor stream, intermittent stream, straining to void, and sensation of incomplete emptying. These are the 7 classical symptoms which we usually assess in these patients and which can be attributable to benign prostatic obstruction. So one important thing to measure, one important thing to know in this lower tract symptoms is this lower tract symptom can be associated with benign prostatic hyperplasia and benign prostatic obstruction, but it is not exclusive to this enlargement. That means there are many other diseases which can lead to lower tract symptoms. So the presence of only lower tract symptom doesn't mean that the patient has got prostatic enlargement, and we can't attribute all the lower tract symptoms to prostatic enlargement alone. There are many other diseases which can lead to prostatic, which can lead to this lower tract obstruction. What are the differential diagnosis? What is the differential diagnosis of this lower tract symptoms? The differential diagnosis of this lower tract symptoms is urethral stricture. There can be bladder neck contracture, bladder stones, whereas urinary tract infection, interstitial cystitis, inflammatory prostatitis, where there are various medications which can cause this lower tract symptoms. Even carcinoma of the prostate as well as carcinoma in situ of the bladder can also result in this lower tract symptom. So as I told you, the symptoms of lower urinary tract symptoms is not specific for prostatic enlargement alone, but it can also be caused by wide variety of other diseases as well. Moving on to some of the pathophysiology of this pathophysiology of this benign prostatic hyperplasia. This old paradigm was there was a small prostate. Whenever there is a small prostate, there was little change in the bladder wall. That is, the bladder wall used to be thin and the bladder wall used to remain normal. Whereas as the prostate gets enlarged, there was thickening of the bladder wall which developed, and it may result in lower tract symptom. This was a old assumption. Moving on to the subsequent paradigm, they also shown that in the normal prostate there was a thin bladder wall, whereas as the enlarged prostate, whether the prostate enlarged, the bladder wall become thickened, and this thickened bladder wall and the changes in the bladder wall detrusor muscle were responsible for this lower tract development in this enlarged prostate patient. Later, they also found that this patients with small prostate also developed increased alpha receptors, which may also result in lower tract symptoms. So ultimately, in the management, we'll be discussing this blockage of this alpha receptors, which was increased due to prostatic enlargement, can result in elevation of symptoms of this patient. So one important thing to know here is, even with a small prostate, there may be increased alpha receptors in the bladder neck area as well as in the bladder wall. Because of this increase in the alpha receptors, that may result in the development of this lower urinary tract symptoms. So whenever there is alpha receptor blockage which occurs, this results in an improvement in the symptoms in these patients. And this is again the same thing which I told. Moving on to the prevalence of BPH in these patients, one important thing to know is BPH is a disease of older age group. As the age advances, the incidence of the prevalence of BPH also increases. So it is, if you consider a people between less than 50 years of age, or if you consider between 40 to 49 per year of age, about 25% of the patients would have developed BPH. Whereas as the age increases, if you take about 70 to 79 year age group, about 80% of the population will have benign prostatic hyperplasia developed. As I already told you, this enlargement of the prostate gland will result in development of this lower tract symptoms. It can be this lower tract symptom can be due to direct bladder outlet obstruction caused by the enlarged prostate. That is called as static component. There's an enlarged prostate which acts as a block to the bladder outlet, and it may result in lower tract symptoms. The other thing which can also result in lower tract symptoms is there is increase in the smooth muscle tone and resistance within the enlarged prostate, which may also lead to the development of this lower tract symptoms in these patients. Moving to the BPH or LUTS pathophysiology, as already discussed, this prostatic hyperplasia will result in bladder outlet obstruction. There are other causes of bladder outlet obstruction which we already discussed, like urethral stricture disease, carcinoma of prostate, etc., which can also result in the same pathophysiology. Whenever there is bladder outlet obstruction, as I told you, there is increased changes which occurs in the bladder wall. That is, there is detrusor response changes which can happen with bladder outlet obstruction, and this detrusor response will result in lower tract symptoms. This detrusor response can also occur as a result of any neurological disease. It can also due to age factor, as the detrusor aging effects can also happen. All this will contribute to the development of lower tract symptoms. So this chart indirectly shows that this development of LUTS is not limited to BPH alone. There are various other diseases can also lead to the development of lower tract symptoms. So it indirectly tells that don't consider that BPH is the cause for patient symptoms. Please be wise in ruling out other diseases as well, which may mimic that there is BPH, but the disease can be different. For example, patients with urethral stricture can have all symptoms of this BPH or LUTS. But if you don't have mind, if you start treating the patient only with according to BPH, then the patient there will be no improvement. So whenever patient presents with lower tract symptoms, it is important for us to consider the other diagnosis as well in evaluating and further management of these patients. So as I already discussed, this is a pathophysiology. There are many physiological changes which happens in the prostatic gland as well as in the bladder neck and bladder wall, which results in development of this lower tract symptom. For example, there is epithelial and stromal proliferation. That is nothing but the histological BPH which first developed. There are various other cellular growth factors which predict the development of this prostate as well as the hypertrophy of the bladder wall. There is some amount of genetic predisposition which happens, and there is autonomic overactivity, some inflammation, etc. All these are the pathophysiological factors where with the development of pathophysiological factors which are involved whenever there is benign prostatic hyperplasia, which ultimately results in the development of lower tract symptoms in these patients. Moving on to the management, what does AUA guidelines say to us? We have got basic management of LUTS and we have got detailed management of LUTS. As I already told you, the important recommended test is a detailed relevant medical history. It's very important. As I told you, BPH is a disease of old age. Many of these patients with benign prostatic hyperplasia will have comorbidities or other neurological disease which may result in the development of lower tract symptoms. So a detailed medical history is a very important part in the management of this patient, followed by assessment of LUTS. As I told you, there are 7 lower tract symptoms which needs to be assessed, like what I told you, the irritative or the storage symptom, that is frequency, urgency, nocturia, as well as the voiding symptoms like house the stream, poor stream, intermittency, straining to void, sensation of incomplete emptying. These are the 7 lower tract symptoms which has to be assessed completely by these patients. So the 7 lower tract symptoms should be assessed for the severity, and we also should assess how much bothersome the symptoms are for the patient. After this lower tract symptoms assessment, a good physical examination is very important. Good physical examination, because a patient may have phimosis as well, and he may be presenting with symptoms related to BPH. So it's very important for us to do a good physical examination as well as local examination. And most important in management of this BPH patient is a digital rectal examination. This digital rectal examination is the most important examination in this elderly patients who present with lower tract symptoms. We should also do certain laboratory tests like basic urine analysis to rule out urinary tract infection. It's very important for us to do the serum PSA examination as well as frequency volume chart has to be done. The detailed management of LUTS includes the recommended tests is validated questionnaires can be done, and frequency volume chart. That is not very important, but it plays an important role in few patients who have got this urgency symptoms, or few patients who have got more of irritative symptoms. Frequency volume charts plays a very important role. What are the other optional tests? The optional tests which are very important in this patients with BPH is the flow rate recording as well as residual urine measurement, which is again plays an important role in management of this patients with BPH. This optional test include uroflowmetry as well as this residual urine measurement. As I told you, the most important examination in this patient is distal rectal examination. This distal rectal examination is very important because it can rule out certain difficult, important things like prostatic cancer. So if the patient has got prostatic cancer, he may also present with LUTS similar to patients with benign enlargement of prostate. So it's very important to do a physical distal rectal examination to rule out prostatic cancer. In the patients with BPH, we find a symmetrically enlarged prostate gland, which is firm in consistency and feels like a tip of a nose. Whereas in case of prostatic cancer, the enlargement is usually asymmetrical and there may be frank nodules which can be palpable, and the prostate is usually stony hard to palpate in presence of prostatic cancer. So this distal rectal examination, as I already told you, plays a very important role, and it helps us to differentiate between the prostatic cancer as well as the prostatic benign prostatic enlargement. This neurological examination is also very important. As I already told you, many neurological disease, for example, if the patient has got any spine problem or any disc problem and there is problem in the lumbar plexus, then these patients can also present with lower tract symptoms. So a focused neurological examination is also a must in these patients with BPH who present with lower tract symptoms. As I told you, one of the most important, though it has been recommended as an optional study by AUA guideline, but one of the most important tests which we do in management of these patients with benign prostatic hyperplasia is the uroflowmetry. This uroflowmetry records the voided volume over time. And the printout, we get a printout which shows the time passed in seconds along the x-axis and the volume and the intensity of the stream along the y-axis. So most of the uroflowmetry, we get the voiding time, flow time, peak flow time to peak flow rate, and most important thing to know is the peak flow rate, which is ml per second, and average flow rate and voided volume. So this is this thing. We consider, as I told you, the one of the most important factor which we get by this uroflowmetry is a peak flow rate, that is Qmax. If the peak flow rate is more than 15 ml per second, then it is considered as a normal uroflow. Whereas if the peak flow rate is less than 10 ml per second, we see in this chart, we can see that the peak flow rate is less than 10 ml per second. That is considered as a obstructed flow pattern. Whereas if the peak flow rate is more than 15 ml per second, it is a normal uroflowmetry curve. In continuation to the evaluation of this patient, we have to, as I already told you, initial evaluation, we have to take the history, distal rectal examination, focused neurological examination, do a urine analysis, PSA testing, and then you classify the patient according to the symptoms. That is IPSS symptoms as a mild and moderate. Mild is when the patient has got IPSS symptoms score of less than 7, it is considered as mild. Most of these patients with mild disease do not require much treatment. But if they develop any worsening of symptoms, we can always start them on a medical line of treatment. Patients with moderate symptoms, you can afford the treatment like watchful waiting, medical therapy, as well as surgery if they're not responding to this medical therapy. So, as I told you, the moderate to severe symptoms, we have to do additional testing like flow rate testing, residual urine measurement, as well as urodynamic study can also be done in places where any neurological issue has to be sorted out. And once it is proven that there is bladder outlet obstruction secondary to prostatic benign prostatic hyperplasia or benign prostatic obstruction is there, then we can start them on a medical line of treatment. Not responding, then we can always surgery is always there. But in this evaluation, it is very important to rule out other causes of prostatic enlargement, other causes of urinary tract symptoms like urethral stricture disease, neurological disease. All these things should be ruled out while evaluating these patients with benign prostatic hyperplasia. So what are the goals whenever we consider these patients with BPH? What are the goals of therapy? Most important thing is the patient should have decrease in symptoms. And second one, the bother score should be decreased and his quality of life should improve. The prostate size should decrease and there should be arrest of further growth. The peak flow, that is uroflowmetry, if you have done uroflowmetry before treatment and after treatment, there should be improvement in the peak flow rate. And it is very important to prevent prevention of long-term outcomes or complication is also very important. These are the goals of therapy in patients with BPH. Moving on to watchful waiting, it is usually recommended in the patients with mild symptoms, that is the IPSS score less than 7, and moderate to severe symptoms also. If the patient has got and is not bothered too much, then also watchful waiting is a means of choice. Patient is monitored by the patient by the physician. Then certain lifestyle modification is usually advised, like amount of fluid to be consumed, avoidance of the coffee, tea, and other drinks has to be managed. And patients should be educated about the need for regular follow-up and need for routine testing should also be advised to the patient whenever you are putting the patient on this watchful waiting. Going on to the medical therapy, the first line of treatment in patients with BPH is the alpha blocker. As we discussed in the pathophysiology, one of the changes which happens whenever there is prostatic enlargement is there is increase in the alpha receptors which happens in the bladder wall as well as in the bladder neck area and the prostatic tissue. Because of this increase in the alpha receptors, this increase in the alpha receptors is considered to be a cause for the patient's lower tract symptoms. So whenever we are blocking this alpha receptors by using alpha blocker drug, then the patient it is found that the patient will improve and the symptoms is going to improve and the patient will get relieved of this lower tract syndrome. This is the basis of using this alpha adrenergic blockers in this patients with prostatic hyperplasia. The other drug which has been used in this patient is 5-alpha reductase inhibitor, because this prostatic enlargement is hormone dependent. So whenever we cut the hormone or the active component of the hormone is avoided, then the prostatic enlargement comes to a halt, and this indirectly will also will also decrease the progression of this benign prostatic hyperplasia. One more drug which is used is antimuscarinics. As already discussed, the lower tract symptoms can be of irritative symptoms or the storage symptoms like frequency, urgency, nocturia. They might not be relieved much by using alpha adrenergic blockers alone. So whenever the patient has got the storage symptoms, it is very important to consider antimuscarinic in their treatment for better relief of symptoms. So moving on to the alpha adrenergic blockers, it is the first line treatment recommended in men with moderate to severe BPH and LUTS. It usually results in rapid improvement in symptoms. How does it act? As we already know, there is increase in the alpha receptor in the bladder neck area as well as in the prostatic tissue. So whenever we give this alpha blocker, there is relaxation of the bladder neck and prostate, resulting in symptomatic improvement. Various drugs which have been approved, that is alpha blocker drugs which have been approved in this treatment of these patients are silodosin, alfuzosin, tamsulosin, doxazosin, and terazosin. Of the three commonly used drugs is tamsulosin, alfuzosin, and silodosin. Others are non-selective blockers. These three are a uroselective blocker, that is silodosin, alfuzosin, and tamsulosin are a alpha 1A receptor selective blocker. This alpha 1A receptor is specifically present in the bladder neck. So whenever we give these three drugs, the dose titration is not required, and they usually experience a fewer side effects as compared to doxazosin and terazosin, which are a non-specific alpha blockers. So the clinical effectiveness of alpha blockers with bothersome and moderate to severe LUTS is similar with the use of these drugs. And common there are certain adverse effects which are seen in this patient with alpha-adrenergic blockers. The common side effects are dizziness and some ejaculatory dysfunction, which is more common with tamsulosin and silodosin, less common with alfuzosin. As I already told you, the second line of drug which is used is 5-alpha reductase inhibitors. So this prostatic enlargement is a hormone-dependent change. So when we give this 5-alpha reductase inhibitor, it prevents the conversion of testosterone to dihydrotestosterone. This dihydrotestosterone is the end product, which is an active metabolite of testosterone, which stimulates the prostatic growth. So whenever we give this 5-alpha reductase inhibitor, testosterone is not converted to dihydrotestosterone. So the growth of prostatic growth is not stimulated. And ultimately, the progress of the disease is affected by if you give this 5-alpha reductase inhibitor. The approved medication for 5-alpha reductase inhibitor, finasteride as well as dutasteride. Antimuscarinic agents. So as I already discussed, whenever the patient has got the storage symptoms of frequency, urgency, nocturia, we should usually combine these patients with antimuscarinic agents so that the relief is better. Along with alpha blocker, antimuscarinic agents are usually given. And these patients with storage symptoms, they benefit well with antimuscarinic agent. Commonly used antimuscarinic agent is tolterodine as well as tolterodine. And recently, solifenacin is also solifenacin, tolterodine, and many other antimuscarinic agents have been used. Usually, we can use it's usually used along with alpha blocker. Alpha blocker is combined with antimuscarinic agents in patients with storage symptoms, so the benefit is better. One of the commonest side effects which we experience whenever we put the patient on this antimuscarinic agents is dry mouth, constipation, and blurred vision. Patients should be educated about the side effects, and then they can be prescribed with this antimuscarinic agents. So, as I already told you, it is antimuscarinic agent is recommended in men with moderate to severe LUTS, and whenever there is symptoms of storage symptoms are more, whereas it is contraindicated in men with bladder outlet obstruction. That means, how do you know? If the patient has got a very high residual urine, then it's better not to use antimuscarinic agents on those patients. And as I told you, various antimuscarinic agents have been used, like darifenacin, tolterodine, solifenacin, tropicium chloride, etc. One of commonly used drugs are tolterodine as well as solifenacin. The adverse effects are dry mouth, constipation, as well as dizziness, which needs to be explained to the patients. Moving on to this thing, as I already told you, the monotherapy with alpha blocker alone is not much efficient. Whereas if the patient has got a prostatic enlargement with the volume of prostate more than 40 grams, then it is recommended that there is a combination therapy is more useful as compared to monotherapy alone. It is very important to combine this alpha blocker like tamsulosin or silodosin or alfuzosin with 5-alpha reductase inhibitor like finasteride or dutasteride. And they have found that this combination reduces the disease progression, and worsening of symptoms is reduced by using this combination therapy with alpha blocker as well as 5-alpha reductase inhibitor. And adverse effects is not very much as compared to the monotherapy alone. So if you do this is one of the study which shows that combination treatment with alpha blocker and 5-alpha reductase inhibitor in patients with moderate to severe LUTS and an increased risk of disease progression. That means it decreases the risk of disease progression if you use combination therapy with this patient with more than 40 ml of prostatic enlargement. So whenever a patient with BPH with more than 40 grams of prostate is present and the patient has got moderate to severe LUTS, it is always better to combine this patient with alpha blocker as well as 5-alpha reductase inhibitor. So this is a meta-analysis which shows that the combination of tamsulosin plus dutasteride provides a good therapeutic effect, and it reduces the BPH related progression, and acute urine retention chances is also decreased whenever you use a combination therapy as compared to monotherapy with tamsulosin alone. And this is a famous combat study. This combat study shows that whenever you combine a 5-alpha reductase, that is tamsulosin, with dutasteride, they reduce the relative risk of acute urinary retention. It also decreases the progression of BPH, and there is greater symptom benefit compared to monotherapy alone. So this is a famous combat trial or combat study, which clearly shows that combination of 5-alpha reductase along with an alpha blocker is very effective as compared to monotherapy alone. But remember, we don't use this combination therapy in all patients, only in patients with moderate to severe LUTS with prostate more than 40 grams. Then this combination therapy is very useful as compared to monotherapy alone. So there are various other studies which shows that combination of silodosin with dutasteride. As I already told you, any alpha blocker can be combined with 5-alpha reductase inhibitor, and this is a study which shows that silodosin with dutasteride, it results in increase in the voided volume, and maximum flow rate was significantly improved as compared to monotherapy alone. And there is significant improvement in the IPSS scoring system, as well as there is decrease in the acute urinary retention rate also whenever you use a combination therapy of silodosin along with dutasteride as compared to monotherapy alone. So as I told you, this antimuscarinic agents can also be combined with 5-alpha, can also be combined with alpha blocker, especially when the patient is having frequency, urgency, nocturia. That is, when the patient is having storage symptoms, then 5-alpha blockers can be combined with antimuscarinic receptors. One important contraindication is it should not be given in patients with increased residual volume. So we have got combinations of tamsulosin along with solifenacin. Tamsulosin can also be combined with tolterodine. The various combinations have been available. So if you use this alpha blocker with muscarinic receptor blocker, it results in relief of the storage symptoms as compared to monotherapy alone. So this is again the same study which shows that use of combination treatment with alpha blocker and muscarinic receptor antagonist in patients with moderate to severe LUTS with storage symptoms has been insufficient with monotherapy with either drug. That means if you use a combination therapy, it is good than using a monotherapy alone. But important is if the patient has got residual urine of more than 150 ml, we can't use this combination of alpha blocker with antimuscarinic agents. One more drug which has been lately used in patients with this BPH with lower urinary tract symptoms is beta-3 agonist. Again, this beta-3 agonist is very important in management of storage symptom. That is, if the patient is having frequency, urgency, nocturia with other lower urinary tract symptoms, that is, the storage symptoms are more predominant, then we can use this beta-3 agonist. What is the mechanism of, what is the pathophysiology, or what is the basis of using this beta-3 agonist? We have seen that beta-3 adrenoreceptors are predominant beta receptors, and they are expressed in the smooth muscle cell of the heterozoa. Whenever there is beta-3 agonist which is given, that is, whenever there is a stimulation of this beta-3 receptors which happens, it causes relaxation of the heterozoa. So whenever the patient has got his urgency, frequency, nocturia, if you give this beta-3 agonist, it stimulates the beta blocker and it results in heterozoa relaxation. So thereby there may be relief of the symptoms of frequency, urgency, nocturia. So one of the beta-3 agonists which has been widely used in these patients with this lower urinary tract symptoms of frequency, urgency, nocturia is mirabegron. Mirabegron has shown that there is significant improvement in overactive bladder as well as symptoms of frequency, urgency, nocturia, which may coexist in these patients with BPH. So BPH can be used. So this beta-3 agonist like mirabegron can be used in treatment of overactive bladder secondary to BPH. So use of beta-3 agonist in men with moderate to severe LUTS who mainly have bladder storage symptoms have been tried and have been very successful. So this is again the review of, as I already told you, this is a combination drug therapy for non-neurogenic lower urinary tract symptom. That means the patient should not have any lower urinary tract symptoms. So combination therapy is very important, and That means combination of either alpha blocker with 5-alpha reductase inhibitor or combination of alpha blocker with antimuscarinic agent is very important for elevation of the symptoms with this thing. Moving on to BPH and sexual dysfunction, it is very important that chances of developing BPH increases with age. Similarly, the sexual dysfunction also increases with age. So treatment, one more important thing is, the first point is nothing but, see, as I already discussed, BPH is a disease of older age group. Even sexual dysfunction is a disease of older age group. Okay, but certain treatment which we use for sexual dysfunction can also result in erectile dysfunction as well as altered ejaculation. For example, if you use tamsulosin, and that can cause erectile dysfunction, and silodosin is known for its altered ejaculation. So whenever you use BPH along with, whenever you treat BPH, we should be warning the patient about this sexual dysfunction which is associated with this treatment. And treatment should be tailored according to the patient preferences. For example, if the patient is very sexually active, then we should take care that these patients should not be prescribed silodosin or tamsulosin. Alfuzosin is supposed to be better in sexually active males, whereas in other elderly patients who are not sexually active, silodosin can be easily prescribed in those patients because they are not bothered much about the sexual dysfunction. So we have also found that certain PDE5 inhibitors like Tadalafil can relieve symptoms of urinary tract symptoms. So in usually younger male patients with lower urinary tract symptoms, Tadalafil alone can be given for treatment of this urinary tract symptoms secondary to BPH. And it has shown that Tadalafil has shown good efficacy and safety for improving lower tract symptoms and erectile dysfunction in men with BPH. Usually a smaller dose, about 5 grams of Tadalafil has been given, and it has shown that there is significant improvement in the maximum flow rate which occurs with the Tadalafil monotherapy. As I already, this comes to an end of the surgical medical treatment of benign prostatic hyperplasia with the bladder outlet obstruction. If the patient is not responding to the combination therapy, and if the patient has got worsening of symptoms like this flow rate is decreasing, the residual urine is increasing, and there is no significant improvement in quality of life, then we should consider surgical treatment. Among the surgical treatment, it is usually indicated to moderate to severe LUTS. And whenever there is BPH related complications like acute retention, as well as if the patient has got recurrent urinary tract infection secondary to BPH, if the patient develops vesicle stone secondary to benign prostatic enlargement, all these things are the indication for surgical treatment. Among surgery, TURP is considered as a benchmark. Any type of TURP. Now we have got various type of TURP like monopolar TURP, which is a gold standard. We also do what is called a saline or bipolar TURP, as well as laser TURP. Any type of TURP is sufficient for treatment of this patient. It usually mainly depends upon the patient factors like what is the size of the prostate to choose the type of surgery, and what is the whether the patient has got any comorbidities. If the patient is on blood thinners, if the prostate is very huge, then laser prostatectomy is usually preferred. For a smaller prostate and patient doesn't have any comorbidities, usually monopolar TURP is sufficient. So ultimately, TURP is considered a benchmark for surgical therapies. Other surgical procedures, which the thing is, we have got open prostatectomy, which is usually out of the thing. We are not doing much about bottom because the morbidity is more, and there is minimally invasive methods which is available. For example, laser, we can do up to 200 gram prostate can be easily done with laser. The other surgical procedures like HIFU, high frequency, high intensity focused ultrasound, has also been tried, and aquatherapy for prostatic enlargement is also in the way. But the gold standard treatment again, TURP remains the gold standard treatment. HIFU, photoselective vaporization of prostate, transurethral electrovaporization of prostate, all have been tried. But the most important thing in these patients is TRP remains the gold standard surgical treatment for this patient with BPH. All other treatments are still in the investigative phase, and none have been approved by FDA or any other authority for treatment of patients. So moving on to the take-home message, finally, we should all remember that all aging patients, BPH is a disease of old age. As the patient gets, as the population becomes older, or as the people become older, they're more prone to develop this BPH. Not all patients with lower tract symptoms will have BPH. As I told you, lower tract symptoms can be caused by wide variety of disease. So don't blindly assume that if the patient has got lower tract symptoms, he has got BPH. It is very important to take a good medical history, do a good relevant examination to rule out other causes of lower tract symptoms. Okay, not all BPH is equal to LUTS, and combination therapy has got a very important role in treatment of this patient with BPH, especially if the patient has got moderate to severe lower tract symptoms with a prostate of more than 40 grams. Then combination therapy is very important in this, plays a very important role in treatment of these patients. Quality of life issues and sexual dysfunction issues as well as should be considered whenever we are planning the treatment of this patient. For example, if the patient is sexually active, younger age group, then the Tadalafil or what is called a PDE5 inhibitor has shown a significant improvement. So we can try treating these patients, younger patients with Tadalafil. Whereas older patient without any sexual dysfunction, we can take silodosin. So the quality of life issues should be considered before planning any treatment on these patients with BPH. I think with this, we come to end of this presentation. Thanks once again for Lupin Pharmaceuticals for providing me this opportunity, and I am open for any questions. Hello.
Thank you, sir. So there are a few greetings from the attendees. I am just putting in a Zoom chat box.
Yeah.
Dear delegates, if you have any query or questions regarding this topic, you can post your question in the chat box. Thank you.
Hello. So no questions, sir.
Yes, sir. I think there are no more queries or confusion from attendees side, sir.
Anyway, thank you. Thanks for this thing.
Thank you, sir. So should we wait or conclude the session, sir? Should we wait or conclude the session, sir?
No, we'll conclude anyway. It's not. It's a straightforward presentation. Thank you.
Okay. No issue, sir. So I would like to thank you on behalf of the organizer for your insightful and educative talk. So thank you.
Thank you. Thank you.
Thank you so much for your time. Thank you.
Thank you.
And thank you to all dear delegates and doctor whoever joined from FB and YouTube. Thank you. So I'm ending this meeting now. Thank you.
Thank you.
So I'm ending this meeting.